welcome everyone. For those of you who don't know, my name is Lori Kelly, and I'm a provincial coordinator with the Alzheimer Society of B.C. And it is very much my pleasure to introduce you today to today's guest presenter, Dr. Sherri Hayden, who is a clinical neuropsychologist and a clinical assistant professor with the Division of Neurology, Department of Medicine at the University of British Columbia. She's also a faculty member of UBC's Women's Health Research Cluster. Over the past 30 years, Dr. Hayden has worked at UBC Hospital in the Clinic for Alzheimer's Disease and Related Disorders, as well as in her private practice at NeuroHealth. Dr. Hayden's clinical practices serve a variety of populations, including neurodegenerative disorders, traumatic brain injury, post-chemotherapy cognitive issues, post-COVID cognitive issues, and mental health-related cognitive issues. Dr. Hayden applies preventative and lifestyle medicine principles to her clinical practice. She is co-founder of Synaptic Travels and Wellness, as well as the nonprofit organization Her Mind Matters Maui, both providing brain and mental health education to women. Dr. Hayden's chapter on non-pharmacological management of symptoms of dementia and their prodromes is contained within the Handbook of Rehabilitation in Older Adults. She's also authored Women in Mind Workbook, the neuroscience of mind-body medicine for optimal cognitive and mental health. You'll find a link to information about that book in today's helpful resources, as well as a number of other links that Dr. Hayden thought you might find interesting. All of this is by way of showing that we are in excellent hands for today's session on frontotemporal dementia. Dr. Hayden is going to speak for the first hour or so, and then she's going to spend some time answering any questions that you have. And on that note, I see Dr. Hayden has her slides up already. I am so delighted to pass it over and to take myself off screen.
Thank you, everyone, and welcome. I'm so pleased. Thank you, Lori, for that introduction. And I'm so pleased to be here to hopefully expand your understanding of frontotemporal dementia. I have been at the clinic for 30 years, the Clinic for Alzheimer's Disease and Related Disorders. And in that context, I've seen many patients with frontotemporal dementia, as well as many different types of dementia. So hopefully this will be helpful to you, and we'll have a good amount of time to discuss and address any specific questions or comments that you have. Just put those in the chat, as Lori has mentioned. Sorry, there we go. So I thought I'd start with first talking about what I do in the context of this field, so you'd have a better understanding of where I'm coming from. I am a clinical neuropsychologist, as Lori said, practicing for about 30 years. And for those of you that might not know, neuropsychology is an applied neuroscience concerned with identifying brain and behavior abnormalities using standardized testing. So what we do is we assess patients with paper and pencil tests, puzzles, things like that to map out brain function. And we typically do that in the clinic over about 4 to 6 hours. So it's a pretty big time commitment, but it gives us a lot of detail or a cognitive map that focuses on assessment of cognition meaning aspects of your thinking, your memory, your language, problem solving, all of that. We also take a look at behavior and emotional factors in the context of brain function. All of this provides critical information that helps me give opinion about diagnosis as well as prognosis. So that means I can sometimes give opinion on rate of decline or what to expect in the future. And it gives me a map of someone's strengths and weaknesses cognitively that might help manage behaviors or symptoms. And we'll be talking about that later on. In the clinic, we also offer serial neuropsychological assessment, so repeated assessment in some cases, not all. that provide a view of performance over time. And this certainly can be critical in certain differential diagnoses, meaning how I differentiate between certain types of dementia or other factors. So a good example is distinguishing between frontotemporal dementia and Alzheimer's disease, or frontotemporal dementia and psychiatric or mental health issues. So we will be talking about all of this further on, but that's sort of what I do, just to give you some context. And so really neuropsychology measures brain function as a reflection of brain structure. And this is quite important in the field of dementia because unfortunately, although some of these diseases, a good example is Alzheimer's disease, involves changes to the brain cells in your brain. We don't have the machine yet. It's not been invented to look at those brain cells. So we do have fancy machines like MRIs, CAT scans, SPECT scans, etc., but those really just look at the structure. So to really understand how things are working can help us have a better picture of where dysfunction might be happening. And when we're looking at function, you know, your brain is kind of arbitrarily divided up into 4 lobes. That's the frontal lobe, the temporal lobe, the parietal lobe, and the occipital lobe. Each lobe is sort of responsible for various functions. There is overlap, of course, because your brain communicates, but the areas that we're going to focus on today are obviously the frontal and the temporal lobes, because typically those are what are affected certainly early on in frontotemporal dementia. And when we look at those areas, what you need to know about the frontal lobes is this is really what I tell patients. This is the executive of your brain. In fact, some of the functions that we refer to when we talk about frontal lobe function are called executive functions. And what that means is that they're complex, higher level functions, higher intellectual functions like reasoning, judgment, problem solving, organizing, that help make decisions and send off information to other parts of the brain. I kind of call the frontal lobes the gates of the brain. So it allows information to come in, it sorts it, it screens out what's relevant and what's not, and sends it off to be stored or processed in other parts of the brain. So the frontal lobes is involved in all of that. It's also involved in screening and moderating behavior and mood to some degree. It's involved in working memory, what many of us might call attention, specifically divided attention. So it's our ability to screen out what's relevant and what's not. And take in a lot of information and still focus on one thing. So the frontal lobes are involved in a lot of complex functions, obviously. Now, the temporal lobes below that are play big roles in aspects of your speech and language, as well as memory, both verbal and visual, depending on the side of the brain we're looking at. It is involved in the expression of some behaviors and emotion, and the processing of some sensory information like hearing and vision. So these are the main areas that are affected in FTD. But before we can really understand frontotemporal dementia, I think we need to understand what normal aging of the brain is. And it may come to a surprise to you that, in fact, your brain is changing probably from your mid-30s onward. Essentially, there's atrophy or shrinkage or neuronal loss. Neurons are the cells in your brain, and there's loss of that tissue over time as we age. So not only do we start to look different as we age, what we look like at 80 is not the same as what we look at like at 30. Our brains at 80 are not the same as they were at 30. And these neuroimages can certainly demonstrate that to you. So these are scans, and you can see from 36 to 85, those brains look a bit different. Those pictures look a bit different. And how they look different is the amount of black space. So if you see the black space inside the skull for each of these images, you can see the older age groups have more black space. And what that tells us is that there is atrophy of the tissue, which is the gray space. And the atrophy of the tissue is the neuronal loss or the shrinkage of the brain tissue that happens with normal aging. This is normal aging. But what you need to know is that people living with dementia will experience more of this kind of loss than in normal aging. And when we look at normal aging towards dementia, it's important to know that there's sort of an interim group or category that we often refer to, and you may have heard of it. It's called mild cognitive impairment, or MCI. I always like to remind people that MCI is not really a diagnosis clinically. It's a catch-all category that helps us understand that a person with MCI has issues that are measurable on tests like those that I administer, but they're not sufficient, so there's not enough of them to meet the criteria that we have for various forms of dementia. So they don't have enough, they have a bit. We know that a certain portion of these people will go on to progress to dementia, and some of them will not. We don't actually know why that is, but we certainly know they do differ from normal aging. And you can see again in the imaging here that there is again more black space for the MCI than there is for the normal aging image. And you can see it in function as well. So it's quite normal as we get older to start to have some issues here and there. So we might miss a bill payment, or we might lose our keys sometimes. We might sometimes not be able to pull a word, or we might even forget the date, especially if we're retired. We're all prone to making poor decisions once in a while. All of that is quite normal in healthy aging. When we're looking at mild cognitive impairment, what you're going to see is just a little more frequency of these issues, more than would have happened with normal aging. So you'll see more challenges with handling bills, maybe misplacing items more often, greater difficulty with communication, maybe losing track of time a little more, or making more frequent poor decisions. So you can see just sort of a little bit of slippage as we move towards MCI. And to really understand that spectrum of normal aging to dementia, I think this is a good illustration. And what you see here is how cognitive changes, so memory, language, executive functions, all of that, how that changes over time when we're looking at people and assessing them. And if you look at normal aging, which is represented by the green arrows, there's a couple of arrows there because really we have to acknowledge that everybody has there are individual differences, and some people cognitively age at a higher level, and some people sort of at a lower level. But what normal aging is defined by is that there isn't a big drop, right? The blue arrow is representing MCI, and as you can see, that arrow is divided. One continues on to kind of mimic normal aging, just a bit of slippage from normal aging, but continues to go in the same pattern. And half of them go down possibly to develop a dementia. The red arrow represents the different stages of dementia. We know that about 25 to 50% of MCI patients may go on to develop a dementia, but that means about 50 to 75% do not. And again, we don't know clinically why that is, but it's important to recognize that you may have deficits that don't quite meet criteria and will continue to not meet criteria ongoing. So these differences between normal aging, MCI, and dementia are also seen in function, as I've said. So you can see overlap here. When we're looking at all three categories, you're seeing occasional lapses in memory, some difficulty with paying attention, and maybe with complex conversations or instruction. But once it becomes more frequent and the difficulty is more prominent, that's when we're beginning to consider MCI. Once all of these symptoms start to affect function, meaning how what activities a person can do day to day, or their mood and behavior, that's when we start to consider or wonder about dementia. So it really is sort of a continuum, but I would say it's important to know that dementia and MCI is not a part of normal aging. It's just that there is some overlap in the things that people experience. So what is dementia? We will focus more on frontotemporal dementia, but in order to understand it, I think you need to understand it in the context of other forms of dementia. So dementia, I always tell patients, is the umbrella term. It's a general term that describes a collection of brain diseases with symptoms, including cognitive change like memory loss, executive issues, language problems, possibly personality change, and these things affect daily activities. What we do know is that Alzheimer's disease is the most prevalent, the most common form of dementia. 60 to 70% of dementia cases are Alzheimer's. This is characterized by cellular changes called amyloid plaques and beta tangles in the brain. And the symptoms early on in the disease, the most prominent symptom will need to be, to meet the criteria of Alzheimer's disease, will need to be memory impairment. There may be other issues, like issues with language, word finding, or other aspects of thinking, but memory impairment will be the bigger impairment in Alzheimer's disease. Now, vascular dementia affects about, it can account for about 10 to 20% of dementia cases, and this is characterized by disease or injury of the blood vessels leading to the brain. The presentation of vascular dementia is variable. It depends on where that disease or injury occurred. So it can result in what we call focal deficits, so very specific deficits depending on the area, and might include impairment of motor skills or other executive functions. Frontal dementia, which is the focus of our talk today, accounts for about 10% of dementia cases. As we noted, it involves the deterioration of frontal and temporal lobes of the brain. And symptoms early on typically involve behavior or personality changes, changes with language, and in some instances, changes with executive function. And the rest of the 10% is really accounted for by other dementias, including Lewy body dementia, dementias related to other conditions like Parkinson's disease, Huntington's disease, etc. So you can see that there's a wide range of conditions. They have some variation in how they present early on and in their prevalence. So it's just important to acknowledge that. Now, to make things complicated, which it is, there is also an umbrella for FTD, or frontotemporal dementia. So frontotemporal dementia is not one disease. There are many clinical manifestations, many subtypes, or what we call variants of frontotemporal dementia, or FTD. Some of these are represented here. I would preface with saying that the terminology used and referenced by various clinicians can vary. Not everyone uses the same terminology, which is unfortunate, but this is just an example of some of the variants that are that we might cite in clinical or research terms. So that would include frontotemporal dementia associated with motor neuron disease. So you're going to see more motor symptoms. The behavioral variant of FTD, which obviously involves more behavior, personality change. Variants of primary progressive aphasia, either semantic or non-fluent variants. Those involve primary language and communication issues. Logopenic variant has a motor component, as does corticobasal syndrome and progressive supranuclear palsy. So these all sort of have slightly different profiles, but they all fall under that umbrella term of FTD, or frontotemporal dementia. Now, we're not going to go through all of the diagnostic criteria in detail. It's a very busy slide, but this is just to remind you that the diagnostic criteria is complicated. As you can see here, this doesn't even cover all of the options that we might consider. But I chose this because it does represent or reflect the fact that there are different neuropsychological profiles for some of these conditions, you can see. And that really is the guiding principle for someone like me when I'm looking at all of those test results and I'm looking for patterns. Really, that's what my job is looking for patterns to see if it matches this condition or that condition, and if there's any other explanation for that pattern. What I tell patients is that it's important to recognize that in this field of dementia care and diagnoses, we are at a disadvantage because we can't look at the cells. And so we are making educated guesses, and that can take time, which I know can be very frustrating when someone is struggling and they're trying to know what their label is. We are pretty good at it over time, but it can take time because it's complicated. And we'll talk about all the complications as we move forward. So one of those complications is the fact that progression in frontotemporal dementia can vary dramatically from person to person. There are, in fact, both the accelerated forms of progression where it's just a couple of years from time of diagnosis to death, as well as a very slow rate of progression over a decade or more for some patients. So there's a lot of variability. But on average, symptoms seem to progress to a more pronounced level over a course of 8 to 10 years. This is sometimes hard to predict, but if we do serial assessments, we can sometimes give you general guidelines in regard to that. Another complication is sex differences, which is beginning to come to the forefront of research. It hasn't been in the past. As a woman, it's a bit of a frustration because women's brain health issues have been understudied. But what we're beginning to see in emerging research is that women and men with FTD may be presenting slightly differently. There are studies that show that women and men with comparable general or intellectual function who have been diagnosed with FTD, the women will perform worse on some of the cognitive tests like language tests, executive tasks, visual spatial tasks, whereas the men will show a higher frequency of behavioral disturbances like apathy, irritability, poor judgment, aggression, hypersexuality. There are also studies that are suggesting that the neurodegeneration, so that atrophy or shrinkage of the frontal and temporal lobes, has to be more severe in women for us to see the symptoms clinically. But men will be symptomatic, meaning they will start to have issues in their life earlier, even with a smaller degree of atrophy. So, you know, we're just at the beginning of understanding these sex differences. So the meaning of that and why that's happening is a bit unclear, but it's important to acknowledge, because the more we know about these specific differences, the better we might be able to address treatment protocols for specific sex differences. So obviously everybody would want to know what the cause of FTD is, and the simple answer is we don't really know. What we do believe is that FTD is typically caused, or in many cases caused, by a buildup of proteins in the frontal and temporal lobes. Literature is suggesting that about, here the slide shows 30%. It varies depending on the study. Between 10 to 30% we believe are genetically related, meaning it's hereditary, it's in the family history. But what that means is 70 to 90% is sporadic, meaning we really don't know why it happens. It's not related to genetics. It's not passed from generation to generation. So we have a long way to go to really understand etiology or cause when we're talking about FTD. But perhaps one way of trying to understand it better is to compare it with a condition that we know more about, and that is Alzheimer's disease. And there certainly are differences between Alzheimer's disease and FTD. You can see that reflected in the images here. You can see that the FTD patient has more black space or atrophy around the sides and the top of the brain scan, which is the frontal and temporal lobes, compared to the Alzheimer's patient. We also know that Alzheimer's tends to affect people at a little older age, typically in the 60s and beyond, whereas FTD on average affects people at a younger age, between 40 and 65. The start time, from the time of start of symptoms, when patients first notice symptoms, to the time of diagnosis with Alzheimer's patients, is usually around 3 years or less. Most patients I see tell me a couple of years is what they say. With FTD, that length of time tends to be longer. So the time between start of symptoms and diagnosis is often more than 3 years for people with FTD. As I've said before, the patterns are somewhat different cognitively. So people with Alzheimer's disease will show memory loss early on in the course of their illness, whereas in FTD, the memory loss develops quite a bit later. Whilst in FTD, you'll see behavior changes, problems with higher level functioning like language and executive functions early on, which would tend to come a bit later with Alzheimer's disease. So there are definitely differences between these conditions that we can see and measure to some degree. Also, neurologists can see some differences in some cases for subvariants of FTD. I won't go through these in detail, but just know that when a neurologist is looking at your scan, they're looking for patterns as well, but they're looking for patterns in the nature of the scan to try and distinguish different types of FTD if they're able. Sometimes it's not always possible, but this is what they're looking for. From my perspective, though, what I'm looking for, obviously, is the cognitive changes that are reflected in the neuropsychological profile. As FTD is a progressive degenerative disorder that manifests itself in behavior, language, and executive function, that's where I look for the conditions. So we're looking at it from a cognitive point of view. And so when we think about the overall symptoms of FTD, I'm not going to get into the specific diagnostic criterias, but when we look at it from an overall perspective, what we're looking for when we're looking for symptoms of FTD are a number of changes, as you can see here. One of the prominent changes early on would be changes in personality, mood, and social behavior. By social behavior, I mean the person's ability to filter and control behavior in a socially appropriate way. For those who suffer from FTD, they often can become what we call disinhibited, meaning they have less control over their behavior and they may say or do things that they wouldn't have said or done before, and or that might be considered a bit socially unacceptable, and that certainly can present challenges. FTD patients also often have issues with communication and language and speech. That can include both expressive language, so their ability to find words, to find names, to put sentences together, as well as receptive language, which means your ability to understand language. Some patients lose their ability to understand the meaning of certain words. I've mentioned several times the importance of executive functions and how that plays a role in FTD. And that means that for FTD patients, they will likely experience early on deteriorating problem-solving skills, problems with planning, organizing themselves. They will have trouble maybe with starting and finishing tasks, with staying focused, especially if there's a lot going on. Their reasoning and judgment can be affected, which can unfortunately affect important things like finance. And motor function can be affected. So we might see issues with balance, with frequency of falls, with their gait or walking, poor coordination, etc. And this slide is, again, a busy slide, but just a reminder for me to emphasize, as if I haven't emphasized it enough, how complicated making this diagnosis is. And that's because not only are there some overlaps with other types of dementia, but there's considerable overlap between the variants, the subtypes of FTD. And this can make it a little more challenging to be very specific about the subtype of FTD. And in fact, in clinical cases, it's not uncommon that we may not be that specific. We might just say this looks like a frontotemporal dementia. We may not be able to be that specific. So just recognize that a lot of these diagnostic criteria are, although good in theory, may not always be so easy to apply to clinical practice. And because of this complication, it's important to know that there's no single test for frontotemporal dementia. What we're looking for as clinicians is we're looking for signs and symptoms of the disease. What are the symptoms and what are the patterns that we see cognitively? And we also are trying to exclude other possible causes. And really, dementia in general, not just FTD, these are diagnoses of exclusion. So what that means is that our job is not only to look for symptoms, but also to make sure there aren't other things explaining those symptoms. This can be quite challenging in FTD because there can be symptoms that mimic other conditions. A good example is how FTD early on with the behavior and personality change can look like certain psychiatric conditions. And in fact, historically, even at the beginning of my career 30 years ago, a lot of FTD patients ended up being admitted to psychiatry into psychiatric hospitals because it was thought that they had developed a psychiatric condition. And it wasn't until they were followed over time or they started to decline that it was recognized that they didn't, in fact, have a primary psychiatric condition. So the way that we do this is we work as a team. There are a number of members of our team at the Alzheimer Clinic. Obviously, I put neuropsychological testing at the top, a little self-serving, but the reason for that is this provides us the map. It's extensive. It provides us an extensive map of cognition. And in my case, I also look at mood and personality to rule out any mental health factors. And it's the pattern of the abnormality that helps me distinguish FTD from other forms of dementia, and in other cases with mental health issues. The physicians in the clinic may order other tests, or your GP may order other tests, including blood tests, sleep studies, brain scans. All of these are to rule out other things. So the goal is to rule out any liver or kidney disease, to rule out sleep apnea, to rule out any tumors or strokes, anything like that that might explain the symptoms that we're seeing cognitively. And although that works very well, it's important to know that there's possible confounds or complications that come to us with each patient, because everyone comes with their own history. And some of that history can affect performance on cognitive tests and influence or impact our ability to make a diagnosis of frontotemporal dementia. And that would include a patient's medical history. So, obviously I'm going to ask detailed questions about medical history, including if there's any sleep disorders, as I've mentioned in the last slide, any history of chronic pain or pain medication dependence, history of excessive alcohol or drug use or abuse. Other medical conditions can also affect cognition. Learning disabilities and developmental delays is a good example. So someone who has always lived with some form of learning disability or developmental delay, as they age, aging is superimposed on that weakness. And what will happen is it will make it look like it's deteriorating at a faster rate than normal aging. And that's just because learning disability has aging superimposed on it, not necessarily that there's a dementia. Other illnesses like diabetes can result in fluctuations in cognition, depending on their state. And obviously history of other neurological conditions like traumatic brain injury, seizures, stroke. Once again, if there's history of that, brain damage to the brain in the past can look like it's worsening over time because aging is superimposed on that prior damage. So it's important to understand that. Psychosocial factors can also impact our ability to make the diagnosis and can impact cognitive function. I would say probably in the clinic, about 50% of the patients I see are primarily mental health or psychiatric issues, and they are not presenting with an evolving dementia. So that tells you how significant psychological factors can be to your cognitive and brain health. So there's going to be a lot of questions about stress and psychosocial issues. What's going on in this person's life? Has there been deaths? Has there been ends of relationship? Has there been job losses? All of these things create stressors that can impact a person's function. Anxiety, worry, rumination, depression, all of that can also impact cognitive function. And all of these things would tend to affect a person's ability to attend. If all of that's going on, it's not uncommon for people with these issues to have problems with attention, which then can affect other areas of function. In my own practice, I've seen that certain personality styles are prone to maybe become what we call hypervigilant or over-focused on changes that are normal for age. Good example are high achieving, so those type A people or high IQ people who have less tolerance for change in their cognition, even when it's just normal aging for age. The same is the case for people with perfectionism or obsessive compulsive. They can just ruminate and, hyper focus on symptoms that really just are reflecting normal aging and age-related changes. And finally, experience and knowledge of dementia can be a risk, mainly because if you've ever been around and cared for someone with dementia of any form, it is quite a traumatic experience. It's obviously quite upsetting and can be distressing. And so it would be, not unusual that someone who cared for their mother would start to wonder if their little occasional forgetfulness is going to turn into that. So it's important to realize that that can also raise risk for a tendency to be hypervigilant to symptoms and can muddy the waters when we're looking at diagnosis. So all of this is to say that, diagnosing any dementia, but particularly FTD, can be a challenge, but we are reasonably good at it. As I said, over time, it can take a bit of time, but we are reasonably good at it. And once diagnosed with frontotemporal dementia, then what do we do? Well, I'm going to focus more on the non-pharmacological management. So that means non-medicine related management, because I am not a physician, but these are things that you can consider in managing symptoms or behaviors that hopefully will be helpful. So again, we're going to talk a little bit about executive functions because they're such an important part of how our brains work, but also they impact almost every other area of our cognitive function. So when we're talking about executive functioning, you can, as I've mentioned before, it's a wide range of abilities, and that includes flexible thinking, so our ability to adjust to unexpected changes, or what we call novelty, to spontaneous behavior. Our frontal lobes allow us to adjust to that. Working memory, our attention, our ability to keep information in our heads while we're working with it. Self-monitoring, so self-awareness, our insight, our ability to understand how our behavior affects others, as well as understand what's happening to us and be aware of it. Planning, organization, prioritizing, all of that is involved. All of those are executive functions. They involve your ability to set goals, to organize yourself, to move from one task to the next, and sequence things appropriately, all very complex functions. Timekeeping and being aware of time and the passing of time is an executive function, as is impulse control. So again, that's the screening of behavior that we have the ability, the frontal lobes allow us to be socially aware, but also to control thoughts we might have when it's not socially appropriate. So when we're mad at our boss, we don't maybe say certain things because it's not appropriate. That's your frontal lobes working and keeping that in so you don't get fired. Starting and stopping tasks is another aspect of frontal function, as is emotional control. So all of these things are controlled by the frontal lobes, and as a consequence with FTD, executive dysfunction can lead to problems in a number of areas. And that includes the FTD patient may have difficulty with focusing, particularly what we call divided attention. So they may have difficulty when there's lots of things going on at once. They get overstimulated and either withdraw or get irritable. They might have issues with starting a task or finishing tasks, problems with planning or organizing their day. There might be a lot of disorganization. They might have problems with coping, with change in plans or spontaneity. That's reflected in the mental flexibility. Controlling behavior response and modulating behavior response. There may be an over response. People getting very, very angry at a very small thing is another symptom for some FTD patients. A lack of insight or self-awareness is also a factor, and this can be quite difficult in managing symptoms, because if someone doesn't understand that they have a problem, they will not see the need to get help or assistance for that problem. So that can create barriers to management and can be quite frustrating. There can be a decreased sensitivity to how their behavior affects others and the needs of others. So a decrease in empathy and problems with decision making and making sound judgments. So all of these are very complex functions and can create a lot of difficulty in the lives of patients with FTD as well as their families. So I thought that it might be helpful to talk about strategies, compensatory strategies that I often share with patients when I see them for managing some of these executive deficits that we will see in FTD. Just know that no one approach necessarily works with each individual. It's all a very individualized thing. It's best to have a toolbox full of different approaches so that you can try different things. And in fact, even with the same patient, one day it might work and the next day it might not. So just know that having a toolbox of things is probably the best approach. So some of the things that I suggest would be to ensure a more calm environment so we can limit sensory stimulation and overstimulation. That might include, calming music in the background if the person is responsive to that. I often, as a yogi and a yoga advocate, encourage breath work. So that means just for both patients and family members, just learning simple breath work techniques like breathing in for 4, holding it, breathing out for 4. That really helps signal to your brain to turn off the stress response, which really can de-escalate certain situations. Approaching an FTD patient with a gentle, calm approach using non-threatening, non-confrontational communication is ideal. Using non-verbal messaging a lot. I talk with my hands a lot, which can support communication. So I'll ask about hearing, I'll ask about their glasses, I'll ask about driving. All of that just assists in the communication process. Keeping communication simple and direct, so limiting the number of steps or items. It's not helpful to ask someone with FTD, can you go get me some milk from the fridge, and then can you go do the laundry and go mow the lawn. That's too many things. It would be better to just say, can you go get me the milk from the fridge? And once that's done, then ask for them to do the laundry if they're able. So one thing at a time until completion. Obviously being reassuring and empathizing and acknowledging concerns, even if they don't seem necessarily reasonable to you. We see this a lot when we're testing. Obviously, as we're testing over the length of a day, patients can become kind of irritated or agitated. And what we want to do is just reassure them. If a patient's constantly saying, I need to go see my wife, we'll say, you know what? I know it's upsetting, but she's just waiting outside. And then we use distraction, because we'll say, okay, well, but why don't we try this task, right? So if you can use distraction or redirection to change their focus, their brains are not shifting or changing focus so easily. So they need some help with that. Keeping routines helps avoid disorientation, but also helps with that mental flexibility issue. If you're changing routines all the time, it can be, discombobulating to someone with FTD and upsetting, and it can result in behavioral problems. Limiting environmental distraction, especially when you're having conversations or important things are happening. So I always tell people, turn off the TV when you're having an important conversation. Don't yell instruction from another room while this FTD patient is doing something, because they might say, yeah, I got it, but they might not get it because their brain hasn't shifted. They're doing this and you're giving them information that they can't focus on. Allowing breaks during family or group events is important, just because of the overstimulation with people, music, etc. So encourage them to take rest breaks. And some people may be able to judge that for themselves, some FTD patients, and some may need assistance. I have had spouses that have said, oh, I can tell when he's about to kind of turn off, either get withdrawn or get agitated. So that's your signal to encourage them to go maybe have a little, 10-minute break or longer in the bedroom to get away from all of this, right? Providing cues for the first step of the task. This is because of the problem with initiation. So sometimes people might seem lazy because they're not doing a lot, but that if it's FTD, it could be related to problems with initiation. So telling the person the first step. A good example of this is I had a patient who was diagnosed with FTD whose wife was used to him doing the vacuuming. And she was very frustrated with him because he wouldn't vacuum. So I asked her, what is it that he does when you ask him to do the vacuuming? And she said, well, he walks to the vacuum closet and then he just stands there. So I explained to her that what she needed to do, because he can't initiate the next sequence, he's probably having trouble shifting to the next step, and he can't initiate it. So she needs to provide cues or reminders of what to do next. So you need to open that closet. Okay, now I need you to take that vacuum. Okay, turn it on. Okay, let's vacuum here. So that seems like a lot of work to get him to do the vacuuming, but if you want him to do the vacuuming, that's the way we need to approach it. Use of calendars or whiteboards for plans of the day are useful for a different reason than we might use them with Alzheimer's patients, where it's more to remind. This is more to give comfort about what's to come, to remove the possibility of novelty or unexpected things happening. It can be helpful to have it available and written if understanding language is not a problem. Providing notice of change in plans, or providing a countdown to the task onset. A good example of that is I've had many patients say, oh, he gets a bit agitated or difficult just before we're about to leave the house. And so I tell them that it can be because of the change from doing this to doing that. So the best thing that you can do, possibly that can work for some, is count them down. Is, okay, George, we're going to leave in 10 minutes. Okay, it's 5 minutes now. We're leaving in 5 minutes. So that just allows the brain to shift to the next thing, and can support that. Now, there can be inappropriate behaviors, and we'll talk about that in a bit, but I think from a caregiver point of view, it's important to recognize that even if someone has FTD, it's okay to set clear boundaries about what's appropriate and what you will and won't accept. So if someone's getting verbally aggressive, it's okay to say, that's inappropriate. I am going to go into the other room and shut the door, and then we'll come back to this, right? Sometimes that just diffuses the situation and resets. I would say avoid pointing out errors and failures of the FTD patient on a constant basis, mainly because not only can this increase feelings of inadequacy in the patient, but can also result in irritability and anger in response to having those things pointed out. It's not going to help their insight, because lack of insight is often part of the disease, so that's not going to help it. And it can sometimes just lead to difficult behaviors. Another thing is consider the environments that you're taking this FTD person to, whether they're suitable. You might have to therefore change what you used to do in your life to accommodate. A good example is I had a lawyer FTD patient and his wife who were used to going to very high-end restaurants and events. And she came to me very upset because he was a little over-familiar with people, a little disinhibited. And so what would happen is they'd be in some very fancy restaurant and he would move his chair and go sit with this other group that he didn't even know and start talking to them. And often they didn't know what to do with him. And so she was horribly embarrassed. And I said, well, the problem is you can't control that environment. So the best thing you can do is change the way that you go out for dinner. Either you do it differently in different kinds of environments, smaller venues or something, or you don't go to those restaurants with him. You would go maybe with your friend instead. And when we're having to make decisions about things, it's important to maybe present only 2 options at a time. So rather than giving 5 options, maybe give 1 at a time. Do you want to go to the park or the beach? Beach. Do you want to go to the beach or go shopping? That sort of thing, instead of presenting them all at once. As we've mentioned, language problems certainly can be a part of some variants of FTD, and that can result in a number of challenges, including problems with forming sentences, speaking in halting or hesitant manner, difficulty with talking or writing, in other words, finding words in those contexts, trouble naming things, and for some people, forgetting the meanings of words. I know some of the talks coming in the next month are going to focus specifically on communication strategies. So I'm only going to focus on this one slide for this. But here are some generalities that you might consider. And that would include limiting communication to one topic at a time whenever possible. It's similar to offering many options to someone with FTD. It's overwhelming and it's difficult to follow for them. Avoid using metaphors or abstract or complex language in communications. And as I've said before, encourage signaling or nonverbal communication, especially if expressing themselves is a challenge. Often we can communicate nonverbally. I would say I always do this, and I encourage families to do this, is to ask permission before providing a substitute word. So it's human nature to want to jump in and give the word if someone's stammering around and trying to communicate. But some people don't want that, and that can lead to some behaviors that you may not be pleased with. So I often ask, is it okay if I give you the word? And some patients say yes, and some say no. Obviously, you would not want to do that in front of other people. You'd want to do that only if you're by yourself. If you're going to be at events with less familiar people, you need to pre-plan your communication options. So have signals that I'm in trouble, I need your help, I can't get a word, so that it's not so obvious. And whenever possible, have one, if there's a group of people, have one person be the communicator to the FTD patient at a time. Again, too many inputs can become overwhelming and can lead to agitation. And for some patients I've seen, written communication works better than oral. They have such difficulty producing words that it's better for them to communicate with me via text or email. There are systems embedded in those platforms that help some people, spell check and grammatical corrections that can help communication. And also providing labels on items at home can facilitate communication between patients and their families in some instances. Now, the last area that I thought I'd touch on is behavior. But before we do that, I just wanted to acknowledge again that stress and mood factors can impact cognitive performance. And so it's critically important that we manage mental health and behavioral issues, not only to help clarify diagnosis, but also as we're moving forward and managing symptoms. Research has shown that people are anxious, depressed, sleep deprived, or exhausted from stress will score poorly on the kind of tests that I administer. These poor scores in those groups don't necessarily mean they will decline, but it does muddy the waters when we're trying to figure out what we're looking at when we have a patient in the clinic. And the great challenge with FTD is that behavioral change can be part of the condition that we're looking at. And some of these behavioral changes can be the most frustrating for family members and other caregivers to deal with. So here are some approaches that I thought I might touch on. Again, not all of them will work for everybody, but it's something to consider. And the first comes with trying to accept rather than challenge someone with FTD, particularly if they're prone to behavioral symptoms. So arguing or reasoning about something may not help you, because really the FTD patient may not be able to control their behavior, or they may not even realize that these behaviors are unusual or upsetting to you. So whenever possible, being as sensitive in approach, and recognize that these behaviors are not intentional. It's the FTD the FTD talking, and trying to move forward with that. And in order to do that, it's critically important that caregivers engage in as much self-care as they're able to incorporate. Taking time out, both for patient and or caregiver, is important, just to take some breaths, to take a few minutes just to reset, as I've said before. Keeping a regular schedule can, as I said before, avoid or prevent behaviors of acting out when there's uncertainty. In FTD patients, certain unusual behaviors like compulsive eating, particularly of sweets and carbohydrates, can happen. And so in some cases, you might need supervision. I had one gentleman who was in his 40s with FTD, and he just ate cake and cookies all day, just ate cake and cookies. And so it came to the point that we needed to tell his family that we need to stop buying cake and cookies, and he needs to be supervised because he also would stuff, which put him at risk for choking. So that's important, and distracting with other activities so that they're not hyper-focusing on finding sugar. And finally, to deal with apathy, give limited choices and offer specific choices. So if you see someone with FTD that seems a bit apathetic, or you think they're being lazy, it's not helpful to say, what do you want to do today? That's too general and open-ended. It's much better to say, do you want to go to the beach or the park? And give them options in that way. So all of that sounds quite challenging and I'm sure distressing, but I like to finish with hope. And that is the hope of preventative brain health. I think it's important to know that although 10 to 30% of FTD cases are genetic or hereditary, we're beginning to see emerging research suggests that risk for dementia might, there is a lot of hope for prevention. And this is reflected in this study in 2020 that found that 40% of worldwide dementia cases, that includes all forms of dementia, 40% are likely attributable or related to modifiable or lifestyle factors. So that's huge. That means 40% of dementia cases may be preventable. And even in the genetic forms, there are susceptibility genes. These genes raise your risk. They don't cause the disease. And with susceptibility genes, if you think of them as a switch, as a light switch, what we're beginning to think turns on that switch and causes the disease is lifestyle. So lifestyle factors are significant and important. And it's important to know that preventative brain health is multifaceted. We won't go through all of the details here because we're getting close to the end, but just know not one thing works. It needs a multitude of things. So diet, hydration, sleep, cutting down on sugar, cutting down on drinking, staying socially connected, mentally active, managing mental health and stress, incorporated mind-body practices like yoga, meditation, or even just the breath work that I mentioned before. As well as getting outside and getting vitamin D. All of these things we believe boost your brain health. And we're seeing a growth in preventative medicine focus in clinical care, both through HealthLink BC, at VCH, in the Brain Wellness Program, and in my own practice. And Laurie mentioned a couple of books that I've been involved in, and another good recommendation is this dementia prevention book through the Klianskis. So I thought I would stop here, and we can maybe address any questions or discussions. So thank you very much.
A lot of questions about sort of the diagnostic process and how the symptoms, which you did go into in some detail, but how the symptoms differ from other types of dementia. People asked about Lewy body dementia, about vascular dementia. And I noticed that on the umbrella slide, you noted that the frontotemporal dementia symptoms include personality changes and language issues. And for example, Lewy body dementia symptoms include hallucinations, disordered sleep, impaired thinking, and motor skills.
Yeah, so I mean, that really is how we differentiate, is we're looking for patterns, as I said. So some of that is based on what patients and their families tell us, and importantly, it's often based on cognitive testing and mood testing for us to see, are those symptoms there or are they perceived? Because sometimes people might think that they have certain symptoms and we're not seeing it. So that may then make me wonder, is there something else going on emotionally, perhaps? So that's what it's very complicated. And I think I certainly emphasize that,
You
but
did.
there are different profiles, and the challenge is that each person will come to us with their own history, as I said. So someone with a certain kind of learning disability, say an ADHD history, might look more frontal because they have these attentional problems, but in fact have Alzheimer's disease. So, it's a challenge, and we typically are fairly good at it as we follow people over time, because it's not just about the pattern that we see at the first time we see you and we assess you. It's about how things change. That's what's telling me what is changing and what pattern. So a good example is psychiatric illness. So mental health issues that affect cognition, I'm going to see more fluctuation over the years. Right.
That's that's really clarifies that. One of the questions that came up that kind of fits with what you were just saying is there a comorbidity or correlation between autism spectrum disorder and frontotemporal dementia, or indeed dementia in general?
I'm not aware of that literature. I mean, here's the problem. And I always tell patients that I've seen many patients who we then discover had some undiagnosed learning disability or other issue, because I'm 60. So in my generation, they didn't really diagnose any of that. Unless you were banging your head against the wall, you just didn't get any attention and you kind of had to figure it out. And so those people never got diagnosed. And because of that, they also never got assessed. And there's no literature on how that ages and what the risks are. So the children in the last, whatever, 10, 20 years who have been assessed and have been labeled, we will have much more information about for them in the future. But the problem is those of us who are hitting a certain vintage, our histories are such that they weren't really assessed, so we don't really know.
Okay, thank you.
But it does affect the same part of the brain, so it can look like it.
Again, that teasing apart is so challenging. Someone asked, how do we access this in-depth assessment?
Yeah, I'm always reluctant to talk about what I do, but I welcome it. Here's what I'm going to say. So I've been there 30 years. There's about 8 neurologists and one neuropsychologist for the province of BC. And so I can't see all the patients that are referred to the clinic that go through the neurologist, right? Because there's 8 of them and one of me. So we have to what we call triage and decide which ones I see. I see people that are complicated or unusual, and I see people with questionable mental health issues, and I see people that are really early on that the physicians can't determine from the scans. So we are a provincial clinic, so anyone in the province of BC can be referred to our clinic if there are concerns about decline. All that has to happen is the family physician needs to refer to the Clinic for Alzheimer's Disease and Related Disorders at UBC Hospital. Yeah, it's 604-822-7031. But we don't take patient referrals. We need a family doctor to refer. So that would just be a phone number you'd give your family doctor to contact, and then they would be informed of the referral process. There is a process. All patients that get referred then get triaged by one of our neurologists, one of the 8. And then it's determined after they've seen one of them if I'm going to see them, right? And then I triage as well and decide the level of urgency.
Is there you were talking about gender differences. Is there a hormonal impact with the gender difference?
Yeah, I mean, we know with Alzheimer's disease, this is an area of passion of mine, and that's what some of those books are about. And it all came because I'm a woman, and I'm a menopausal woman. And so I noticed changes in my own cognition and realized that there was nothing really published or helpful to me. And so what we do know is that estrogen does play a role in your brain and how it ages. Estrogen is neuroprotective, meaning that it protects women's brains during reproductive years. And so we're actually at lower risk for a number of things when we are still menstruating. But once we hit menopause and estrogen levels drop, we are actually at higher risk for certain types of dementia. The FTD forms are difficult. We don't have as much literature on that, but what we do know is that women are more susceptible to Alzheimer's disease. About 2 out of 3 Alzheimer's patients are women, and it's not because of age or longevity. It's not because they live longer. And we do think it's because of estrogen. We used to think that estrogen was possibly a risk for certain cancers, but that literature has since been found to be faulty. So I encourage all women to educate themselves. Some of that is in my own book. There's another very good book called The XX Brain by Lisa Mosconi. It's available on Amazon. And she talks about risk factors, cognitive and brain health risk factors for women.
Great. I'm just letting people know that that is, in fact, linked in the helpful resources document. Yeah. So that's great. When you were talking about the genetic effects, someone said, if it's inherited, is it usually the same type of dementia?
Yeah, I mean, by definition, there are different genes, and I'm not a geneticist, so I can't get into the genes, but typically when we're looking at genetic forms, like I said, a good majority of them are susceptibility genes, meaning that just increases your risk. It doesn't cause the disease, right? But in general, those genes would produce the same type of disease, that they wouldn't present with different variants. So it's kind of like cancer. You can have a history of breast cancer in a family, and then this person might get I don't know, bone cancer. And it's just unfortunate that there's all these other cancers, but they're not related, right?
Great. Again, you were talking about symptoms around frontotemporal dementia, and some of them were physical symptoms. And so this person says, will all frontotemporal dementia patients have the physical issues?
No. So that early on, no. So, I mean, the reality with dementias is that they're progressive, right? So as any of these diseases, including Alzheimer's disease and all these variants of frontotemporal dementia, as they progress and get into the later stage, to be honest, I've worked consulting on units with more advanced dementias as well, helping nursing staff manage. And the reality is at that point, people have different diagnoses, but they don't necessarily look different anymore because it's affected the brain to a degree that all aspects of function are affected. So the answer is some variants of FTD that I mentioned do have specific motor changes. Some don't. Motor changes happen with all dementias as they progress.
Someone asked, how does an individual's grief process complicate the dementia journey? This happened to be someone whose parent has been diagnosed with dementia and the other parent just died.
So that's huge. I mean, we have to recognize, I guess it's always, I'm a neuropsychologist, but I'm a psychologist. So, it's always been a frustration of mine that mental health issues are under acknowledged, even in healthcare. But the reality is mental health has a huge impact on all aspects of your thinking, and that would include grief. Because here's what's happening if someone has grief or depression or anxiety or any of those things. What's happening in your brain is there are chemical changes because that's how you feel that way. But also what's happening is your brain has trouble with focus, because in the background, you've got all these feelings that you're dealing with, and it's distracting you from focusing. So then what happens is later when I say, do you remember when I said this? No. Right? A good example is a worrier who's worrying, and I'm sitting with them and they're worrying about getting Alzheimer's disease, and they're ruminating and they're worrying. The reality is all of that worry is then distracting them. So later when their husband says, remember she said this, she'll go, no, I don't remember that. And then she's going to say, see, I can't remember. But in fact, it's related to the interference that anxiety or depression or grief has with our function. We need to be kinder to ourselves and acknowledge that these things are significant and can impact your function. And if they are impacting your function to the point that you can't do things day to day, get support, get help. There's professional help available.
Great. Thank you so much for that. It's one thing I find really reassuring about what you're presenting is how similar much of what you are presenting today, how similar it is and relates to things that we traditionally say when we're just presenting about any dementia. And so really appreciate that. Are delusions common in frontotemporal dementia?
They can be. They don't tend to be like the first symptom, but they can be in some patients. I've had unusual delusions, or maybe what I would better characterize as misperceptions. And so those are the people that always, I mentioned some patients would end up in psychiatry. That's where they would get diagnosed with some psychosis, late onset psychosis, when in fact it was an FTD. So it does happen. It's not common, really common, but it does happen. I have seen patients with that.
And my mom has all the symptoms of frontotemporal dementia. She also has anosognosia. Is that an FTD symptom?
Yeah, so anosognosia is just the medical term for lack of insight, neurological lack of insight. So when we say lack of insight, that's actually a psychological term. So that would be someone who's depressed who denies that they're depressed, right? So that's lack of insight. When it becomes organic because of brain changes related to FTD, that's called anosognosia. So that's just one of the symptoms that I had mentioned. So yes, it's part of FTD often. And it can be a big challenge because as I said, if someone lacks insight or has anosognosia, they're going to not see the need to be assessed or to get any help, and they're going to get irritated if you suggest to do that. So it's very difficult to navigate.
And certainly something that is shared with caregivers of many, many different types of dementia. Thank you so much for your time today. This was truly an extraordinary session, just chock full of information.
Great. Well, it was lovely to be here. I wish you all the best, and I may come across some of you in my practice in years to come. So yeah, take care.